Well, hello and welcome to HealthLine this Tuesday evening. I'm Jennifer Blomquist. I have the privilege of hosting the show, and I'm so glad you joined us. If you're one of our regulars, you know how it goes. We're live in the studio, and we love to have you call in and ask our guests questions. We have an orthopedic surgeon with us tonight, so excited to learn about all the things he has to share with us. If you want to ask a question, you can do so anytime, starting right about now. So there's the phone number at the bottom of the screen, and we keep it up for you on the screen throughout the show. So it's 969-2720. It is still a free call if you're outside of Fort Wayne, as long as you put an 866 in front of there. And like I said, if you're familiar with the show, you know how it goes. But if you're a newcomer, we can take your question live, where you call in. A call screener will not just throw you on the air. They will talk to you for a second or two, and then they'll put your name up on the computer screen that I have here, and then we'll call you up, and you can ask the doctor your question live, which is great because you can interact with the doctor, and maybe he wants to ask you more questions to better answer your questions. So that's one option. But if you're maybe on the shy side or prefer to have us ask the question for you, you can do that as well. Just relay that to the call screener, and I'll ask Dr. Liu your question for you. So let's go ahead and meet our guest this evening. It's his first time joining us, Dr. David Liu. Thank you so much.
Jennifer, thanks for having me. It's a pleasure to be here.
I appreciate you coming. I know you have a very heavy caseload, very heavy schedule, so we appreciate you guys sharing your time with us. You are an orthopedic surgeon.
I am.
Specializing in hip and knee replacement.
Correct. Yep, adult reconstruction, so that's the technical term for someone who does carpentry on the bones, fixing hips and knee arthritis.
That's really what it is. You know, when you think about it, it's almost like a carpenter's job, sophisticated carpenter's job. I would imagine everybody probably knows somebody who's had either a hip or a knee replaced. Now, normally, I find that it's an older crowd that does it, but are you seeing that? I mean, but people are so much more active today, and I see a lot of people, even in their 30s and 40s, still doing a lot of sports or running. So are you finding that some people are even starting
We're definitely
younger?
seeing younger and younger patients that are very active to begin with, so they're more prone to injuries, and sometimes those injuries can lead to trauma that really put a strain on their hip joint and knee joint, and they are more prone to early arthritis. And sometimes congenital issues also lead to significant disease of the joints too. So we take care of patients from all ages. So adolescents even.
Well, you know, and that's just it, because it's not unusual today for kids to participate in multiple sports. And now everything's year round. You know, there used to just be a baseball season was, you know, early spring through midsummer, and now these kids train year round for these sports. And that's one thing I hear a lot of adults say is they pay a price for that later in life. Any advice for young people, or, you know, what to do to avoid having issues like that?
I always tell my patients that what I do, the type of surgery I do, is totally for quality of life. So my job, my role is really to get them back on their feet and get them back to enjoying the things that they love doing to begin with. So if they're tolerating the pain symptoms, I would say continue to do what you do. Staying active, staying healthy is just great for your overall health and well-being. So the goal of what I try to essentially do is to get back the life that they enjoyed before. So it's a quality of life surgery.
And I was going to ask you about that, because we've had some orthopedic surgeons come on, your colleagues, who have said sometimes maybe somebody will have an injury or, you know, wear and tear type of issue. And they'll tell the patient, you know, I can fix it, but I can't turn back the hands of time. So you may not, even though you're getting a new knee and maybe you're 70, it's not really going to be like when you were 30.
It's the technology has changed so much. And we're doing more and more research to be able to create implants that give patients a more natural feel to their hip and knee joints. But it's never going to be as what they had growing up. It's never really going to be their native joint, as much as we try to get them to that point.
I know with the knees, a lot of times it's an elective surgery. Because, you know, a lot of times the doctors will say, you know, or the patient will ask, well, when should I do this? And I know your colleagues have said, you tell me. So it seems like that's not so much trauma, but I feel like with hips, it's more like, oh, somebody had a fall or some trauma. Is that true primarily for hips?
Hip arthritis is also a big deal, and that's more or less an elective surgery as well. So again, the beauty of what I do is the timing of it, a lot of it depends on the patient. So during the summer months, sometimes it's hard to convince patients to have surgery because they want to enjoy their pool time, they want to enjoy time with their families. But really, In terms of a trauma standpoint, that's a completely different scenario. So
Okay.
hip fractures will sometimes require a hip replacement to fix.
Yeah.
And yeah, those certainly can't wait because it's really leads to high morbidity and mortality in the patient in those cases.
So is one easier than the other, a hip replacement versus a knee, or is it vary by patient depending on their situation?
I think from a surgical standpoint, I personally feel like hips are a little bit easier
Really?
to do.
Okay.
It's one cut instead of multiple cuts with a knee replacement.
Okay.
And I think from a recovery standpoint, that kind of shows as well. Typically, I tell my patients that knee replacements are a lot harder to recover from. There's more soft tissue swelling involved,
Okay.
A lot of more stiffness involved, and requires a lot more physical therapy.
And the hip, we were talking before the show,
Sure.
Hip patients, they're a lot of times up and standing
Oh, yeah.
like later
Yeah.
that day. That
yeah.
always amazes me.
For sure, I try not to limit my patients at all after surgery. So the goal is to
Okay.
really give them the life that they had before, get them up and moving, get them back to the kind of life that they were enjoying before. So I get them up, walking, really no weight bearing restrictions, let them walk on it right away, let them shower right away. So
Wow, okay.
yeah, I think the quicker we can get patients back to where their activity levels were, the faster they'll recover.
Well, and nobody wants to lay around.
No.
You know, I mean, most people don't. I
Sure.
don't know, my kids, some of my kids do, but
Right.
but I think most adults just,
Right.
they don't want to have this gigantic hiccup in their life. They want to just kind of
Yeah.
keep going.
Yeah.
So.
Yeah. For sure.
Well, doctor, we do have a call from somebody, but they wanted me to ask the question for
Okay,
them. So
sure.
let's see. This was Dee. She said, "Why are infection rates high with replacement surgeries?"
It is, we're placing essentially a foreign body inside the joint. In terms of the overall rate of infection, we've done such a great job over the years of continuing to gain knowledge of what causes infections, the risk factors for causing infections, that traditionally in a patient without significant risk factors, infection rates typically under 1%,
Okay.
especially for high volume surgeons.
Yeah.
Because one of the things that are associated with infection after a joint replacement is how long the surgery takes.
Oh.
So for someone who does a lot of hips and knee replacements, their surgical time is going to be a lot shorter than
Sure.
someone who doesn't do as many.
Okay.
And certainly patient factors are a big thing that we worry about. So a lot of the things that we work on from optimizing their overall outcome is to see what kind of medical problems that they have. So I feel like the big trifecta for leading to increased risk of infections and complications, high BMI or obesity
Yeah.
causes a lot of issues just because there's more dissection and more soft tissue to go through. Smoking is a big deal. And then diabetes
Yeah.
is associated with a lot of different complications because I feel like diabetes affects all systems in our body.
And we, you know, and that's one thing we talk about. We do all different kinds of specialties on this program, but it's, you know, that weight issue, that is so common amongst, I mean, when we do cancer programs,
Sure.
when, you know, any other types that we've done integrated medicine, and all these physicians are saying, try and do your best to keep your
Yeah.
weight under
Yeah.
control,
Yeah.
you know, lead
Yeah.
a healthy, I hate to say healthy lifestyle, that sounds
Right.
boring, but
Yeah.
there's a lot of good ways
Yeah.
to still enjoy life and be healthy.
Yeah, I feel like a lot of times it's not necessarily the weight, it's more so sort of the manifestation of
Okay.
the disease state of someone that probably has a lot of other issues going on that are causing it.
Sure.
And probably the biggest challenge that we have is facing a patient that has significant weight issues and really bone-on-bone arthritis.
Oh, yeah.
It's really hard for them to do any sort of activities and exercises to lose the weight. So that's kind of where we run into significant challenges.
Yeah.
But you know, there's a lot of good medications out there now that people have really jumped on the bandwagon. So it'll be interesting to see it over the next couple of years how those new medications affect the overall outcomes of patients and their arthritis.
So if you were to have a hip or a knee replaced, are you a lot of times going to end up on medication long term? I mean, I realize pain medicine's probably essential in the beginning, but what does the long term look like?
Typically not. Again, with the opioid epidemic that's going on around the country, we're not really allowed to prescribe long-term pain medicine anymore.
Okay.
And I try to avoid giving patients a lot of pain medicine before surgery, just because it makes their pain a lot harder to control.
Okay.
And they'll require more opioids after surgery, which leads to a lot of complications. Ultimately, the goal is to get them back on their feet and hopefully take away a lot of the debilitating pain that they had before. And so really I prescribe approximately 2 or 3 weeks of medications afterwards, usually a strong narcotic pain medicine because their pain is going to be pretty high, at least for the first few days, sometimes up to a couple of weeks after a knee replacement.
Okay.
I usually do an anti-inflammatory medication as well to calm down some of the swelling and inflammation, and occasionally I'll add in a muscle relaxant because some of the spasms lead to pain too. So we try to hit it from all different angles to mitigate some of the pain symptoms that people have.
Yeah, I was wondering, do you typically send these patients home same day, or are these any of these surgeries outpatient, or does it vary?
A lot of these are, and I
Yeah.
feel like one of the things that accelerated it was probably during COVID when we were trying to avoid the hospital as much as
out.
possible. So, we try to push patients more to the outpatient setting within a safe and manner to do so. If patients that are otherwise healthy and have good help at home, I always tell patients that you're probably going to be more comfortable in your own bed rather than sleeping in a hospital bed. And the pathways that we have created to get patients back to their activity levels, it's really no different than the medication that you're going to get in the hospital are going to be no different than what I prescribe you back home. So,
no reason to really
correct.
stay.
Yeah.
Stay unless you want to.
Yeah. Probably the biggest, I would say the biggest thing is likely pain control. And the other biggest thing is usually for male patients, if they have prostate issues, sometimes the ability to void and pee afterwards is the big thing that are probably keeping them in the hospital.
Okay.
Yep.
Well, no, it's nice to know that you have, a lot of us would at least have that option of,
Sure.
of being able to return home.
Yeah,
I do think
yeah.
people are more comfortable in that environment.
Yeah, I leave that up to the patient to decide too. Some are very
Sure.
motivated, others would prefer to have a night in a hospital, and that's totally fine in my book.
Yeah.
Okay, whatever they're comfortable with.
That's what my dad was so worried because he had
Sure.
to have some surgery on his knee,
Yeah.
and even though my mom was perfectly capable and willing to take care of him,
Yeah.
he just said he felt better. And he just stayed that one night, and then it gave him a little boost of confidence, and then he went home the next day.
And we take patients from all over, so a lot of patients will drive an hour just to see us for surgery, so that's another big thing.
Oh yeah, the long car ride.
Yeah.
So
Yeah.
perfectly understandable.
Mm-hmm.
We welcome your questions, so please don't be shy. That's why we keep that phone number up through the entire program. But we only have Dr. Lou here until a little before 8 o'clock. So take advantage of his time here with us, and he has a wealth of knowledge he can share with you. It's 969-2720. Again, it's still a free call if you put 866 in front of there, just in case you're outside of Fort Wayne. We did have someone else call, Doctor, and wanted me to ask the question for you. I apologize if I'm mispronouncing this name. I believe it's Bays. Wanted to know, do you have to continue physical therapy once you get your range of motion back?
Yep.
Good question.
I'm guessing the caller is asking about knee replacements, because that's probably the biggest thing that we worry about with knee replacements, getting that range of motion back. So aggressive physical therapy after a knee replacement is absolutely crucial. And I would say once you're at that point where you can get your baseline range of motion back, the best thing you can do is just continue to stay active and get back to the activities that you enjoy. Occasionally, patients still get quite stiff after 6 weeks. In that case, we either do more aggressive physical therapy, and if they still can't get their range of motion back, sometimes we have to take that patient back to the operating room to do a little manipulation just to break up some of the soft tissue and scar tissue.
Okay. Gosh, I guess you don't usually hear about people, though, that have to have it more surgery afterwards. So is that
it's not usually a surgery.
Number?
It's more just, we put them kind of asleep, and we give them a little bit of sedation and a nerve block, and then we literally just crunch on their leg until the scar tissue breaks up. And
all right. Well, it's good to know.
Pretty medieval stuff.
I was going to say, I remember when I was in graduate school, I lived in a building with a lot of medical students, and some of the things they told me, I thought, okay, but you have to do what you have to do to make it work.
Hopefully that answered the question, and essentially, once the physical therapist clears you, and once you kind of get yourself checked out by the operating surgeon, essentially get back to everything that you're wanting to do. Really, we typically tend to live between 5 to 120 degrees of range of motion for the knee.
Okay.
So I tell my patients, if they can get to 90 degrees at 2 weeks, they're right on track. And at 6 weeks, if they're past 100 degrees, they should be able to get the last remaining 20 degrees without any issues.
So how often do you typically have to see a knee patient and a hip replacement patient post-op?
Post-op?
Yeah.
Typically 2 weeks just for a wound check, because that's how long it usually takes for the wound to heal. And then usually it depends on the surgeon, but most surgeons, I would say, see patients at 6 weeks just for an x-ray, just to make sure that things are lined up and that they're progressing with their activity level and their functional status.
And then is that kind of it?
After that, it really just depends on the patient and how well they're doing. I would say typically for hip patients at 6 weeks, they're good to go.
They're good
you
to
can
go.
let them fly.
Right.
They can
That's
do whatever
nice.
they want. For knee patients, sometimes they're still having a lot of pain at that point, maybe a lot of swelling. So they need a little bit more TLC. And so they might have to come back in another 6 weeks just to make sure that they're progressing.
Yeah.
Yeah.
Well, we were talking about the physical therapy, and I've taken a number of my children to physical therapy, and it's so different today than when I went, high school and college age. It's a very supportive and positive environment. It's really not scary, and it really, a lot of them aren't even like a medical setting. It's a softer.
Yeah, it's like a gym.
It really is. A lot of them call it the gym. You know, a lot of the therapists do, but it's that whole industry has changed, and I think is much more patient friendly.
Yeah, and there's a lot of science that goes behind it as well. So
Just
a lot of the therapists
setting.
have doctorates and everything. So
They
they
now,
really spend a long time studying their art, studying their craft. So they're absolutely crucial to what we're able to accomplish.
Yeah.
So I always tell patients, the surgery for me is the easy part. The hard part is really what they can do afterwards to get their motion back, get their function back.
Yeah.
Yep.
I don't know. My kids always liked their physical therapist a lot, so that was good, because a lot of them are really passionate about what they do, as are the physicians too.
Yeah.
Let's see, I want to encourage everybody one more time. They just showed us a card maybe a minute or two ago that we're down to 10 minutes, less than 10 minutes now. So if you have a question, please do so sooner rather than later, 969-2720. Somebody in the meantime called in, Catherine called in, and she said that she has arthritis and degenerative disc disease. Now her doctor is recommending a spinal cord stimulator.
Ooh.
I have not heard of that.
Yeah.
She wanted to know what the pros and cons of that stimulator would be.
I don't place them myself. I do see a lot of chronic back pain patients, unfortunately, that require this. I don't think I'm the expert to answer the pros and cons of putting in a spinal cord stimulator.
Oh, so it involves being
it's
put
a little
in.
procedure,
Okay.
little metal implant that goes in that continues to, provide medicine to the spinal cord to help with pain control, essentially. So it's something that we definitely see quite often, just concomitant spinal disease and then hip arthritis. A lot of it is quite linked, unfortunately. So one of the things that I do is to really come up with the correct diagnosis. Sometimes patients that come in with hip pain don't necessarily have hip arthritis. It could be coming from their back, and vice versa.
Is that kind of similar? I mean, I'm thinking of, like for diabetic patients, they might have an insulin pump.
Correct.
Is it kind of that same idea where you can adjust how much medication's released?
Yep.
Okay.
And oftentimes, if they get their back either fixed, fused, or get their pain under control, sometimes it really helps with the rest of their joint disease.
Okay. All right. Well, good to know. It gives her something to think about, weighing that. Sure. Let's see. We got a call from somebody named, it's either Anna or Anna. How do doctors pick the implants that are used? Because I know from talking to your colleagues, it's like going grocery shopping. There are several.
Correct. Yeah. There's so many different companies out there, and all of them kind of take the best parts of what they do, and then there's a lot of small companies that are doing the same thing. They kind of see what else is out there and try to find that niche. For me, I would say the way I pick my implants is based on what I was comfortable with, based on what I was taught during my training.
Okay.
And I also look at the literature. It's very important. So we have a joint registry called the American Joint Registry. So it tracks all of the joint replacements by the big centers, and a lot of hospitals, a lot of groups are joining that effort. It's probably the biggest joint registry in the world right now. So because of research like that, we're able to see long-term how well those different implants do. So for me, I base it off of, one, the research, if they have a good track record, if patients tend to do well, and two, just based off of my own training, what I'm comfortable with. One thing that patients need to realize is that there are a lot of conflicts of interest from surgeons as well, and hopefully the surgeons are able to disclose everything in a truthful manner, because sometimes they might have some royalties from the companies themselves.
Gosh, I didn't think about that.
They could be doing research, and they could be just contributing and working with the company to improve their products. But there's some conflicts involved that I think the patients should be aware of.
Yeah, that's a good point to bring up. And one thing I was thinking about when you were talking about this, does a person's insurance dictate what kind of implant, because I didn't know if they
Yeah.
vary in price
Yeah.
a lot. Or?
And they can to an extent.
Okay.
A lot of times what the hospital groups or the practices will kind of dictate what implants you're allowed to use just based on negotiations with the companies themselves.
Okay.
Insurance companies typically don't dictate the type of implant that you use unless you have to get pre-authorized for a specific implant. There's definitely custom implants out there for specific conditions that's going to cost a lot more. Revision implants definitely cost a lot more money to have. So,
yeah, a lot good
Yeah.
to think about if
Sure.
you're going to go through
Sure.
that surgery. And are they all made out of titanium steel, or?
It depends on how they're used. Usually for a knee replacement, the femoral component is some sort of cobalt chrome. There's companies out there that are trying to move away from metal implants just because some patients complain of metal allergies. So it might be made out of a gold coating or other types of coating to
That's
avoid
interesting. Okay.
that potential reaction. Usually the tibial base plate is made out of titanium, and then there's a plastic insert. Typically hip implants are all titanium unless you use like a cemented stem, in which case you have to have a slightly harder, shinier type of metal. And usually that's like a stainless steel or a cobalt chrome.
All right. Yeah, I thought they were all metal. I didn't
Yeah.
realize there were some other.
Yep. There's some different alloys involved,
varieties.
yep, for sure.
He says he has a whole collection of
I
these
do.
at
I
his
wish I
house,
could have
so
brought 'em.
He's
I-
going to bring. That's why we'll
I
have
do.
you back next time and have you
I'll
bring
show you
those.
the gold implants that I have.
Yeah, I have never seen one like that. I've just seen the titanium one.
Sure.
So I'm going to try and quickly answer one.
Sure.
Get one more question in here, Doctor. Let's see. This was from Martha. Said, what do you decide to do to an anterior approach or posterior approach? Is one better than the other? I'm assuming that's
For the hip.
Yeah.
Yeah. It's a very hot topic still. Still debated at a lot of our conferences that we go to. Usually for younger surgeons that are coming out of training, I tell them to do whatever is most comfortable for them. I think the anterior approach is nice in the sense that patients typically tend to recover a lot faster. You go between muscle layers instead of through muscle layers, so there's usually less pain, typically a smaller incision. It's a little bit more technically challenging, so there are complications associated with that early on in someone's practice. A posterior approach is probably still one of the most common approaches that's used. The downside of that is slightly higher risk of dislocation, but they all tend to do very well long term. So that the thing that's different between the anterior approach and the posterior approach is probably early on in terms of recovery. And in terms of how I personally choose between those types of approaches, sometimes it depends on the patient, really.
Sure.
When you have skinny patients, you really can't go wrong with either approach. They're both pretty easy. Sometimes on the bigger patients, you kind of have to see if they have a large soft tissue fold that might prevent you from healing the wound appropriately. So that's the big thing that we can get concerned about with an anterior approach. So yeah, a lot of it is patient dependent, and some surgeons are more comfortable doing anterior approaches on pretty much everybody without any BMI restrictions.
All right. Well, if you're in this situation where you need to have this surgery, that's a good thing to take into consideration.
Yeah, it's a great question.
I don't know if we can squeeze in one more.
Sure.
See, Becky said she had a knee replacement 15 years ago, and she said when I have, or when she kneels, she has some pain. Anything she can do about that?
That's a tough one. I think that's still a pretty common problem with knee replacements. One of the big things that patients complain about is that they're no longer able to kneel. A lot of times that incision is right down on the front, so you get some scar tissue, and then you get still some nerve pain that's associated with that incision. I would say use some sort of padding when you have to do any type of work, either outside or cleaning up inside the house. Yeah. I tend to cheat my incision over one way to avoid being directly on the kneecap.
Sure.
So time will tell if that, if my patient's 15 years down the road has less complaints of knee pain. So
I can relate to all the kneeling this time of year, weeding and all that stuff.
Yeah, it's definitely
things you do outside.
Becky, it's definitely a common problem. I think a lot of patients have it.
Yeah. Oh, that's unfortunate. But I guess you have to weigh all the pros and cons when you're making decisions about what kind of surgery to do.
Right.
So unfortunately, we are out of time. I told you it would go fast, and it really does. So again, this is Dr. David Liu. We so appreciate you coming on tonight and
Thanks, Jennifer.
helping
Thanks for
everybody
having
out. Yeah, I know we always learn so much on the show. It's a great program. Stay tuned. There is going to be another HealthLine next Tuesday. Mark Evans will be hosting it, and I believe it is about pain management, I believe. So you can check that out next week. In the meantime, I'm Jennifer Blomquist. Take care. Have a really nice rest of your week, and we'll see you next Tuesday. Bye-bye.
The preceding program on PBS Fort Wayne was made possible in part by...
It's a new day at Parkview, another day to rise up and make life better for those around us. Whether that means pushing the boundaries of what's been possible, taking big strides, or sitting with a patient long after a shift has ended. At Parkview, we don't just do what's expected. We do what's best for you and your family. And we're determined to do it even better tomorrow. Every person, every day. That's the kind of healthcare we believe in. Parkview Health. We believe in better.